Hi, everybody. We're joined by Dr. Daniel DeBrule. He's a clinical psychologist and also a health behavior coordinator at the Houston VA Medical Center. He also works as an assistant professor at the Baylor College of Medicine and also runs a private practice. So welcome, Daniel.
Thank you. Glad to be here.
Great. So happy to have you on the show today. We really want to zoom in on a lot of your work with health promotion that you do with the VA. And kind of just first starting off, tell us a little bit about your journey, your path, and also what is health promotion?
Sure. Sounds good. So it's been a circuitous path for me. I began graduate school with some interest in suicide from my undergraduate years working with Calhoun and Tedeschi, and at that time I worked with my major professor, Lillian Range, on mostly writing interventions. And some of my interests and passion for suicidology, to be quite honest, were somewhat dormant for a few years until reaching the Indiana University in South Bend, where I worked with John McIntosh and over the years started to kind of carve out a niche for suicide research in that area of the country. And then after that, I was really working in the academic field. I learned how to be a presenter and conduct certain workshops like assessing and managing suicide risk, which is a program out of the SPRC here in Washington, D.C. But as luck would have it, that stint came to an end, and I found my way down to the Houston VA. The cold winters and all the snow had a little bit to do with that, and just kind of looking to get back to the area where I did my training, and really enjoyed like the New Orleans Gulf Coast area. And Houston's really been great. I've now been able to really rekindle some of my interest and passion for suicide, but now really looking at a facility level, not simply just doing research or having a few students that I work with on in my lab, and really thinking about some larger initiatives for the over 100,000 veterans that we serve in the Houston area. And so my role predominantly is as the Health Promotion Disease Prevention Manager, and what that entails is simply coordinating and arranging for a variety of interventions for various health behaviors. We also train some of our physicians and nurses, and we work throughout the facility, even in our community clinics, building programs out there that all focus on health promotion and disease prevention.
Excellent. And, we'd really like to zoom in on that for today because a lot of times when we think about suicide, we don't necessarily talk about it in terms of health promotion, and I think it's really important to take that sort of promotion angle. So again, what is health promotion, or give us some examples of what health promoting behaviors look like?
Sure, absolutely. So really our program is mostly positioned to combat three of the main problematic health behaviors, and these are tobacco use, inactivity, and poor diet. So in a lot of these cases, if you can have someone who might be at risk to leave this earth 10 years prior by helping them to quit smoking before age 40, we can give them 9 to 10 years of extra life. Of course, obesity is yet another rampant problem, not only in our country, but also in the VA in particular. The rates of obesity for veterans range from about 70% to 80%. So we have a program that is nationwide in the VA called the MOVE program that seeks to help veterans to increase activity as well as understand their diets a little bit better. And in addition to that, we also have programs for various immunizations, for stress management, for trying to maintain safety in different aspects of life, as well as just trying to be much more thorough and much more proactive for the veteran in accessing and focusing on their care.
Great. That's really helpful, thinking of it, like you said, as these health-promoting behaviors that can really prolong and allow people to live a higher quality, more successful, healthy life. So tell us what that looks like in the VA system. So I understand there's these behavioral health coordinators and or health behavior coordinators, rather.
Yep.
Tell us a little bit about that and how they're embedded in the teams.
That was a really good catch, because oftentimes people will confuse us. And if you think of behavioral health, you often think of maybe just another way to talk about mental health. And, our program is a bit distinct, whereas we're really on a given day or a given week, veterans can take part in these programs when they're willing and when they're available. So a lot of our programs are open access. They're not mandatory. So the veteran can, for example, walk right into our tobacco cessation group any Wednesday or Thursday. They don't need an appointment. They don't have to ensure that their particular doctor or social worker or psychologist is there. We have a rotating list of facilitators for our groups. So the veterans often will come in and get a lot of psychoeducation. They'll often leave with materials like our tobacco cessation program. We have a 70-page manual with all kinds of tips and techniques and helpful education about nicotine replacement, for example. And then in other programs like MOVE, we usually have them come in for 16 weeks straight, and we have a certain curriculum. I usually teach 2 of those 16-week courses. They're mostly managed by the dietitians that I work with. And the things that I tend to focus on map to the cognitive behavioral triad. To focus, one of the sessions I lead is on mastering action, so I really focus on the behavioral component, and the other one is mind over matter, where we really dig deep into cognition and how we can modulate that for weight management.
Very interesting. And when we think of these as upstream suicide prevention strategies, how do you see that?
That's a great question. So I think I was actually just having a conversation with Dr. Tom Ellis, who has been in the Houston area for many years now and done a lot of great work at the Menninger Clinic. And he was mentioning that about a decade ago, he had authored a paper on how some of these health behaviors do lead to certain areas of suicide risk. And unfortunately, some of that research hasn't quite made it to prime time yet. So I feel like my job is really to connect those dots. And one of the major ways that I see that is the VA has a new whole health initiative. So it can either be consistent with or maybe a little bit separate from the health promotion field. So Whole Health is looking to ask veterans to participate in their health care in a very comprehensive way and to make sure that a lot of providers are on board, and invites them to consider alternative therapy means such as yoga, tai chi, acupuncture, massage. So these aren't quite as evidence-based as what we might offer in smoking cessation or weight management. But one major component of the new Whole Health Initiative is to make sure that as many veterans as possible, and maybe in a few years, every single veteran going through the system has an opportunity and executes, in most cases, a personalized health plan. So this tells the clinician, not just that's working with them, but because our notes are able to be seen by any provider, I could execute a personalized health plan where a veteran tells me what really matters to them, what gives them a sense of joy in life, and what they want their health for. And also we might focus on certain areas that they would like to prioritize. That information then goes to their doctor, their nurse, to any mental health coordinator, and often I will take the time to even co-sign them to where they'll get an alert to review it. And the major way I see this playing out is to connect this with safety planning. Safety planning being a very tried and true and probably one of our most frequently utilized interventions for suicide prevention. We definitely have found in the VA system that that's an area where we can perhaps mobilize even closer content. In some cases, maybe the safety plan is completed, but yet there's not as much time spent really digging deep into the veteran's unique qualities and really building that relationship, which, as many of us in the psychotherapy realm know, is one of our best predictors of outcome. So one way is to connect the personalized health planning with safety planning. The other ways are, I think, a bit more general and would be a little bit more difficult to connect specifically, in that there's a wide literature on medical illness and health problems that will either exacerbate or possibly trigger suicidal ideation and perhaps to some degrees suicidal behavior. A veteran, for example, that has poor self-care and ends up having to deal with type 2 diabetes or COPD or some of these, maybe not terminal illnesses but very complex illnesses, might then feel a sense of perceived burdensomeness. So I think a lot of what we're doing in our health promotion disease prevention program, as well as with this new Whole Health Initiative, simply give veterans many options to cope. And one reason I think that it makes sense to then include this on the safety plan is the veteran already knows about maybe a few things they can do to cope. Maybe they can do a yoga class. Maybe they can, find acupuncture in their community. Maybe they can work on their activity level, which again will boost serotonin and, maybe have a protective value for them.
Excellent. Yeah, that's really great to kind of see the big picture about how health-promoting behaviors can increase the quality of life and therefore be protective against suicide risk.
Mm-hmm. Absolutely.
So talk to us a little bit more about how the safety plan is augmented or enhanced through health coaching.
Sure. So this is a program that I'm really just starting to develop in the VA system. And luckily for me, our executives and our upper-level management have now gone to a program where any employee such as myself can submit a program as part of like a Shark Tank type of situation. So this is really the idea that I'm hoping to apply, and then maybe it will be seen and enacted in other VAs. But in ours, the major way in which safety planning has come up in the work that we've done thus far, because the Whole Health, and I should mention that the Whole Health Initiative is really in its infancy. So we're just now really arranging introductory classes and our Tai Chi and yoga classes and that sort of thing. So maybe more to say that in the next year or two. But for right now, we find that even when veterans will come in and they're looking to get help for tobacco use or for an individual session for move, there's been some really interesting findings where veterans can come in, and maybe it's due to an ongoing crisis. Maybe it's because myself or someone of my team, often my trainees, are very comfortable and thorough with asking about suicidality. And, of course, many of us clinicians try to do that consistently every visit. Or maybe, for example, the veteran mentions chronic pain and suicidality around that. But whatever the case might be, we have often done safety plans not planned by us as part of the session, because it may become clear that what this veteran might need long-term is smoking cessation or weight management, but today they just need to be safe and they need to have different mechanisms to go through. I must say, too, that one way in which I'm trying to champion this cause is to really invite other health behavior coordinators and HPDP program managers to follow suit. Many of them have expertise in just prevention generally, but not specific to suicide. So I think thus far safety planning does come up for us in primary care, whereas maybe my other colleagues might not feel quite as competent or comfortable and would refer that to their primary care mental health team. I've certainly done that in a few cases, but largely when we've already built that relationship with a veteran and they're sitting in front of us, because I have this expertise and this experience, I'm willing to just go ahead and do the safety plan as part of their health behavior session.
Excellent. And I just want to kind of zoom in on one health behavior for a minute that I think doesn't get enough attention. It's tobacco use. Mm-hmm. And first of all, what do we know? Does it have any relationship with suicide and suicide risk?
Absolutely. I don't think the relationship has been clarified fully, but a few things that we know about tobacco use and suicide. One is that tobacco use will decrease serotonin levels and monoamine oxidase levels. So right off the top, that type of substance will make it more difficult for people to really manage things like depression and anxiety. And we do find that when people stop smoking, they typically have a lower incidence of relapse for depression. Some would argue there's pretty significant anxiety and stress in the week or two as they're quitting, but normally we would connect them with nicotine replacement. So what we do know is that people who do smoke tend to have higher rates of depression, higher rates of anxiety, and tend to have higher rates of stress. However, what we've found so far in the literature, there's not a preponderance of evidence that will show us that when people do stop smoking, that will then directly reduce their suicide risk. But another important piece to this puzzle is that many veterans and other members are given Chantix when they're asking to stop smoking. And we find that of course, Chantix, varenicline, has a really high efficacy rate in certain studies, between 30 to 40%, which is about as good as you can get for smoking cessation. But many providers are reluctant to prescribe this, especially if someone has had any mental health history whatsoever. Some of the recent research is starting to really challenge that. We're not finding that Chantix tends to have this, really considerable risk of suicide. It's something to monitor. It's something to definitely, think about carefully and to really educate the veteran or any other client about. But, what we're seeing now is that it might be bupropion or Wellbutrin that's offered, and that's a, traditional antidepressant that many found kind of accidentally will aid their tobacco use. But what I'm also working on is trying to build more education around Chantix so that can be more comfortably and confidently prescribed. These are definitely not my decisions to make, but I do feel like trying to educate and invite our providers to review some of the recent literature may enable them to then prescribe Chantix and hopefully help the veteran not just with their tobacco use. And just anecdotally, some of the patients I've worked with, one in particular had a really profound history with suicidality, and who's a survivor themselves, said that for one reason or another, for them particularly, Chantix actually kind of helped to, they seemed a bit more grounded. And, I don't know if this is an idiosyncratic effect or whatnot, but not having the medical background. But, I think those are a few things, where our neurotransmitters are affected by smoking. Depression, anxiety are more common. And then hopefully certain medications that are usually open for people to use, some individuals with a history of depression or suicidality may find that challenging in a conversation with their provider. But, we're working on changing the conversation about that as well.
Sure, some promising avenues there. Mm-hmm. And I understand the Houston VA also has some sort of innovative approaches to helping veterans quit smoking. Mm-hmm. Could you tell us a little bit about some of the programs that you all offer besides the medication-assisted?
Yeah, absolutely. So our VA is currently working on designing and implementing some different stress management classes that will hopefully augment care there. We also have had... based on feedback from our veterans, our classes are typically offered in the afternoon, and most VA employees are there between 8 to 4:30. But so many veterans have actually asked for other methods that we now have in our facility. I offer a occasional Saturday workshop for tobacco cessation, but on the national level, the VHA is really doing some cool stuff. We have the 1-855-QUIT-VET hotline, which is a free-to-use tobacco quit line. It's managed through the same contract that helps the National Cancer Service. And we even have an app called Stay Quit Coach. So veterans, especially some of these younger veterans, we find that some research shows that the incidence of smoking is much higher among our younger veterans who've served in Iraq and Afghanistan. So for many of them who may either not have very much contact with VA or may have really busy schedules, the 1-855-QUIT-VET hotline as well as the Stay Quit Coach app are good options. We also have a texting program called Smoke Free Vet. So this is an interactive texting program where a veteran can enroll and they'll get constant reminders about, hey, how's your quit date's coming up in a week. Try to go ahead and prepare. Or if the veteran has an urge, they can type in urge into the texting program, and it will give them prompts like, well, see if you can take a walk outside for a bit, or most cravings only last 5 minutes. Can you maybe try to call a friend for support, and they can type in urge 10 times and get 10 different prompts. So we've got some more interactive interventions that we're using now. And in addition to that, in our program, we're also looking to build a telehealth option for veterans who are in remote areas in addition to that.
That's fascinating. I'm really loving all the cool resources and, again, apps and different things that we can certainly link to and include with the notes with this podcast so folks can check them out. I assume these apps are free.
Absolutely. Everything, and I want to make one big point that nationwide, every single VA has a health promotion disease prevention program. They have a health behavior coordinator such as myself that you can, if you call the operator, ask for the health behavior coordinator, and we normally have all of the information on any kind of health promotion group that's going on. But yeah, absolutely. These programs are just continuing to grow, bigger over time.
Excellent. Well, Daniel, I know there's a lot more to cover, but for today, we want to just kind of close it out with any final thoughts you have for us.
I just want to say a few things. One is that I really do invite people to, especially those who are looking at their careers. The VA has been quite kind to me over the years, really given me a lot of opportunity, and it's a system that, like any other, is imperfect, but one in which I think the rewards are just immense. The VA was great with myself when I lost my internship after Hurricane Katrina. I just really love being in Houston and having the access to so many of my colleagues and resources there in the largest medical center of the world. But I also want to give just a little bit of thanks to AAS, these conferences and the type of programs and just the minds that I come into contact with and spirits has really been remarkable. So.
And how can folks reach you if they want to touch in or hear more about your work or just get in touch with you about some of these resources?
Sure, absolutely. Anyone who's in the VA system, just look me up in Outlook, Daniel DeBrule. And I also have a personal email if anyone has questions about this podcast, dr.debrule@gmail.com.
Excellent. Well, thanks for being here.
It's been a pleasure. Thank you.